All right, let's jump right into this explainer. If you're a junior doctor stepping into the ICU or the ER, you are going to be managing critically ill, mechanically ventilated patients. And inevitably, that machine is going to start making noise. Today, we're going to build a clear, systematic approach to troubleshooting ventilator alarms, pulling directly from the leading critical care texts and ventilator manuals. So, picture this. You're covering the unit, the alarms suddenly start blaring, and let's be real, a little bit of panic sets in. What is the very first thing you actually do? It's incredibly easy to get tunnel vision and just stare blankly at the flashing lights on the machine. But to be effective, we have to completely reframe how we view these alerts. Check out this quote from our emergency medicine sources. An alarm on the vent should never be ignored, and these alarms should be thought of as a pre-code situation. Literally a pre-code situation. Ventilated patients are at huge risk for sudden deterioration. This is a high-stakes moment that demands respect, but it requires a methodical response, not panic. Just take a look at this modern ventilator interface with all those numbers, waveforms, and touch screens. Yeah, it basically looks like a spaceship cockpit. As a junior doctor trying to process all of this data at once while a patient is tanking, that's a recipe for total cognitive overload. We need to simplify. Which brings us to the golden rule. Always, absolutely always, assess the patient before you look at the machine. The vent gives us great data, sure, but the human being in the bed has to dictate the urgency and direction of your response. To get a handle on this, we're going to walk through 6 quick steps today. First, assessing the patient. Then, tackling high-pressure alarms, followed by finding leaks with low-pressure alarms. Next, high-frequency and apnea alarms. After that, the dopes troubleshooting mnemonic. And finally, what to do when they're totally unstable, disconnecting and bagging. All right, section 1, assess the patient first, setting up a step-by-step response. Having a step-by-step approach keeps you from missing life-threatening stuff while you're messing with buttons. Step 1, look at the patient. Are they turning blue? Agitated? Is their chest actually rising? Step 2, check the screen to identify the specific alarm. Step 3, check the airway. Is the tube kinked or displaced? Step 4, literally trace the plastic tubing from the vent to the patient to check for disconnects or water buildup. And step 5, review the vent settings. Moving on to section 2. Tackling high-pressure alarms, which is probably the first major alarm you'll run into. So what does a high-pressure alarm actually mean? Basically, the machine is trying to give a breath, but it's hitting a wall. Too much pushback. Vents are smart. They want to prevent blowing a lung, so they have a preset limit, usually 10 to 15 centimeters of water above normal. Hit that limit, the alarm blares, and the vent cuts the breath short to prevent injury. Now think of high-pressure causes in 2 big buckets, airway resistance and lung compliance. Resistance issues are like a blocked pipe. The patient is biting the tube, they've got a massive mucus plug, or they're having a bronchospasm. Compliance, on the other hand, means the lung tissue itself is stiff and hard to inflate. Think pneumothorax, pulmonary edema, or ARDS. Splitting it up this way, total game changer for narrowing down your diagnosis fast. Section 3, finding leaks. Dealing with low-pressure alarms. Low-pressure alarms are exactly what they sound like. Air is escaping before it hits the lungs. The patient isn't getting their breath, so you've got to act quickly. You're hunting for a physical disconnect. Did the tubing pop off? Is a humidifier connection loose? Or, and this happens all the time, is the tube's cuff deflated? If you hear air escaping right out of the patient's mouth, you've probably found your cuff leak. Okay, section 4, high-frequency and apnea alarms. Let's talk about respiratory rate issues. When you get a high-frequency alarm, the vent is saying the respiratory rate is too high. But here's the catch. You have to figure out if it's the patient or the machine. Is the patient genuinely distressed, hypoxic, or in pain? Or is it just auto-triggering? Fluid bouncing around in the tubing or a small leak can actually trick the vent into thinking the patient is taking a breath. It's essentially a false alarm, but you have to know how to spot it. That brings us to section 5, the dopes troubleshooting mnemonic. This is your cognitive anchor. When the room is loud and your heart rate is spiking, you need a mental checklist. Enter dopes. D is for displacement. Did the tube slip out or slide down too far? O is for obstruction, a mucus plug or a kinked tube. P is for pneumothorax. Did a lung pop under pressure? E is for equipment failure, like a power or gas loss. And S is for stacked breaths, or auto-peep, where they aren't exhaling fully and pressure is dangerously building up. Memorize DOPS, and you'll catch almost any crisis.
Finally, Section 6, when unstable, disconnect, and bag, your absolute ultimate failsafe.
Listen, if you've run through dopes and the patient is actively crashing, you need a bailout. Our sources pulled this direct protocol from Penn Medicine, and it hits the nail on the head. If there is a suspected issue with the mechanical ventilator and/or ventilation is ineffective, place the ventilator on standby, remove the patient, and support the patient with the resuscitation bag. It really is that simple. Never, ever forget that you can just take the complex machine completely out of the equation. By popping them off the vent and grabbing a manual resuscitation bag, with a bacterial filter attached, of course, you instantly bypass any equipment failure. Plus, you take manual control. You can literally feel the resistance of their lungs right in your own hands. You'll know right away if it's an obstruction or a pneumothorax, all while you safely oxygenate them and wait for backup. So, wrapping this explainer up, I hope you feel a bit more ready to systematically tackle those terrifying alarms. You can master every knob on that interface, you can learn all about compliance, and you can memorize every mnemonic in the book. But here is the real question to leave you with. In the middle of a massive crisis at 2 a.m., will you remember to step back and look at the patient first?